Okay, it's 9. Hello everyone. Good evening, good afternoon, Dr. Nishal, and good morning to all people everywhere in the world. Today, I want to welcome all of you on behalf of Saudi Ophthalmological Society to our 5th webinar, which is entitled Congenital Corneal Opacities. We are honored to have Dr. Nishal as our presenter today. Dr. Nishal has his medical degree from King's College Hospital, Medical School, University of London in 1988, and then he trained in ophthalmology in Oxford and Birmingham in the United Kingdom, and complete fellowship in ophthalmology at the Hospital for Sick Children in Toronto, Canada. In 1998, he joined Great Ormond Street Hospital in London, and then in 2012, Dr. Nishal moved to Pittsburgh and he joined the University of Pittsburgh Medical Center Children's Hospital as a chief of the Division of Ophthalmology, Sterilization and Adult Mortality. Now, Dr. Nishal is the Chief Division of Pediatric Ophthalmology, Strabismus and Adult Mortality. He's the Director of Pediatric Program Development at University of Pittsburgh Medical Center Eye Center and Professor of Ophthalmology at University of Pittsburgh School of Medicine, and his Medical Director of Telemedicine Service, University of Pittsburgh Medical Center, Children's Hospital of Pittsburgh. Dr. Nishal has a lot of contribution to the ophthalmology field, and everyone who works in pediatric ophthalmology, in anterior segment disorders, corneal diseases, cataract, glaucoma, appreciate his contribution to it. Furthermore, Dr. Nishal is the founding member for the World Society of Pediatric Ophthalmology and Strabismus. And this society is doing great work, and we are all of us enjoying their webinar, which is weekly occurring on Saturdays afternoon, which is 4 p.m. in our time and 2 p.m. in London time. And we can follow them in their website and their YouTube channel. And here in screenshot, we can see some of their previous activity, and tomorrow they have another one. So, Dr. Nishal, you are welcome. We're honored to have you. And I will let the field to you to start. For people, if you have questions, you can type them in question and answer area, and you can go to them by the end of the webinar. Thank you, Dr. Nishal.
Thank you very much. If you could stop sharing.
Yeah.
Or should I? Let me just. I think I can do it. There we go. I got it.
Okay.
No, I still see yours. Oh, I've got it. I've got it. Thank you so much. Okay. Sorry about that. Here we go. I hope you can see that. Is that okay?
That's clear. You can go ahead. Thank you.
Okay, good. So, look, first, I would like to say thank you so much for inviting me. I'm humbled. I'm honored to be asked to speak to the Saudi Ophthalmological Society. I hope that what I'm going to share with you, this is my experience over the last, 21 years now in pediatric ophthalmology, with a special interest in the anterior segment, especially the cornea. These are my disclosures. I think there's nothing there really relevant except that I'm the executive director of WSPOS. I always like to show this slide. You know, in our passage through our professional lives, family is very important, and my wife always has supported me, and my kids now are a joy to be with. It's my youngest son's 20th birthday today, so a special celebration with the Saudi Ophthalmological Society. Okay, this is a rock. This rock is in Petra. If you've ever been to Petra, if you look at this rock, some of you will see an elephant. Here is the trunk, here is the ears, this is the eye. If you stand over here and you look at this rock, you see this. Now, some of you will see a fish. There's the eye, there's the big fin, there's the mouth. But some of you will see a skull. That is the socket, that is the jawbone. And the reason why I show this picture is that in medicine, the reason why there is controversy and sometimes lack of clarity and consensus is because as human beings, we look at the same thing and sometimes we come out with different opinions. The opinion I'm about to share with you is the opinion that I have formed over 21 years looking after children with congenital corneal opacity. If I show you this, it will take you a little while to figure out what I've written, but if I show it to you the way you're used to looking at it, you can read it immediately. So what does that tell you? It tells you I can condition the way that you look at things. So remember, already we look at the same things in different ways depending on how our brains are structured. Now I can condition you to look at something in a certain way. That conditioning in medical school and in ophthalmological training for congenital corneal opacity was to come up with this terminology, stumped. That's a terrible classification, right? Sclerocornea, trauma, ulcer, metabolic, Peters, endothelial dystrophy, dermoid. All it does is it helps you remember things, but it does not tell you what is going on. And for me, the pathophysiology and the pathomechanism always leads to decision-making and prognosis. So the issues really in this field are nomenclature and classification. When I was a fellow with David Rootman and Alex Levin back in 1998, we did this study where we basically looked at children who were born with corneal opacities. We made a clinical diagnosis, then we did a UBM, and we saw what the difference was. Let me show you a case. This child often will be considered as having sclerocornea. If you look at the child, you've got the anterization of the limbal arcades, and you've got a diffuse opacity. But if you do the UBM, you see a keratolenticular adhesion. Well, keratolenticular adhesions are supposed to be Peters anomaly type 2. So which is it? Is it sclerocornea or is it Peters anomaly type 2? And what we found in the study was that in 40% of all the cases where a clinical diagnosis has been made, the UBM changed the diagnosis. And when the UBM changed the diagnosis, it was the correct diagnosis on histological examination. So think about that. 2 out of every 5 eyes that you make a clinical diagnosis based only on what you see in congenital corneal opacities, it's incorrect. This was another paper that I was not involved in this. They did whole exome sequence analysis of Peters anomaly. And what I want to show you is that Peters anomaly is not a diagnosis. It's a sign. It's a bit like doing whole exome sequence analysis of somebody who has a cough. You would never do that. You would never do that. So these are some of the papers that I've been involved with. And because of this work, I eventually came up with a classification that was the refined form of which was published in Current Opinions. And this is what the classification is. The classification says that there are primary congenital corneal opacities and there are secondary congenital corneal opacities. The secondary ones can be developmental and they can be acquired. The primary ones, the only ones that are primary, are things that affect the cornea only. So corneal dystrophies, cornea plana, what we used to call isolated sclerocornea, corneal structural defects due to dermoids, and this entity called CYP1B1 cytopathy. If you will give me some time, I'm going to take you on a journey of pictures and information and share some knowledge. Now, the first thing is, this is my lead genetic counselor, Hannah Skanger. The first thing is that people say to me, we don't necessarily always have a high-frequency ultrasound. And what I want to show you is that you don't need one. The image on your top right is a linear ultrasound scan, which is this thing over here. And believe it or not, this is available in every anesthetic department that does anesthesia because they use this hockey stick probe to find veins. And as long as it's less than 15 megahertz, you can put it on the eye and look, you can see the anterior segment. The vector ultrasound, which is what we're more used to looking at, does not do that. The vector ultrasound doesn't allow you to look at the front of the eye because it only has 1 crystal. The linear ultrasound has 50 crystals that are not moving. So this is the same eye, linear ultrasound scan, vector ultrasound scan. Don't ask me why we still stick with vector. I've bought linear ultrasound scans since 1999. The point is, you do not need a high frequency ultrasound to be able to image the anterior segment. Okay, so let me show you this case. This is a case of a child who came to me with congenital corneal opacities in both eyes. This is the linear ultrasound. It clearly shows that there is an adhesion between the cornea and the lens. The UBM shows it more clearly, but this clearly shows it. So let's go back to this classification. And this one is a little bit more detailed because I've gone into the acquired in more detail, but let's stick to the basic classification. Corneal dystrophies, congenital hereditary endothelial dystrophies, we know surgically, you know surgically that they do well. In Saudi Arabia, there have been some very good papers that have come out. And now, of course, with Massimo Busin's work, you can do an endothelial keratoplasty. You don't have to do a penetrating keratoplasty. Why do they work so well? Because it is only the cornea that is affected. Other corneal dystrophies like posterior polymorphous dystrophy, they also do well. Now, I'm not saying that operating on an infant is easy, but if you know the technique and you know what you have to do post-operatively, the outcomes are much better than the outcomes might be suggested in the older papers. In this particular case, you can see the double layering of the endothelium, and this is a cytokeratin stain. This is the epithelialization of the corneal endothelium that is seen in PPMD. Please remember, there is only one type of CHED now. What we used to call CHED2 is the only type of CHED. And the reason for that is that CHED, all the CHED1s previously were actually a form of PPMD. This is a child with a very rare endothelial dystrophy. It's called X-linked endothelial corneal dystrophy. And what I want to show you is something that is fundamental. The UBM in this cornea shows that the edema is not anterior. The edema is posterior. Look at that. And there is a clear demarcation line. Why? Why is there a clear demarcation line? Well, it turns out phylogenetically, if you look through species and time and evolution, reptiles who came out of the water into land had a double layer of cornea. And as we have evolved, those two layers have fused into one cornea, but that two-layer segmentation still exists, with the anterior stroma being much more tightly packed and the posterior stroma less so. So if you see this condition, look, the edema is not in the epithelial layers or in the anterior stroma, it's in the posterior stroma. And I think that's a very important point, because some of these congenital opacities, if you go back and look at the histology, they are tending to regress into two layers. Now, all of these conditions were referred to me with a diagnosis of sclerocornea. And I put it to you that any diagnosis that is so variable is not a diagnosis, it's a sign. And even the sign is poorly defined. Poorly defined. The problem is that geneticists have relied very heavily on ophthalmologists to tell them what is going on. And if you look at this, this is MLS, which is microphthalmia with linear skin defects, or microphthalmia, dermal aplasia, sclerocornea. Now, to me, this is the same child, two eyes. This isn't sclerocornea. Look at this. And more importantly, look at the anterior chamber. It's completely disrupted. This is not a corneal problem. So why call it sclerocornea? This is what they used to call isolated sclerocornea, which is a bad term. It's cornea plana. These children do not need a corneal transplant. They have high hyperopia because of a flat cornea. Look, this child's hyperopia is so high, you can actually see his optic nerve without needing an ophthalmoscope. They need a good contact lens fitting, and you have to be careful that when they hit the second decade of life, they will develop glaucoma. So you have to be prepared to go in and take that lens out and put an implant in. Now, often the capsular bag diameter is normal. It's just that they have a microcornea, and you have to be aware of that because the capsular bag diameter is what influences whether you can put an implant in the eye or not. If you see cornea plana, always check for syndactyly of the third and fourth digits, and also check the teeth, because this is oculo-dento-digital syndrome. Oculo-dento-digital syndrome. And you have to check the kidneys if you make that diagnosis. So let's talk about now corneal dermoids. Corneal dermoids, if you can shave them and then do a deep anterior lamellar keratoplasty, you change these children's lives. But there are some that you have to be careful of. For example, this child has golden Haar syndrome. Again, you can shave it and then do a lamellar keratoplasty, because this is quite a big dermoid and probably quite deep. That's golden Haar syndrome. You see that there with the preauricular tags. But look at this, please. This is courtesy of Andrea Molinari from Chile, who sent me this and asked me what I thought was going on. If you see this lipodermoid affecting the cornea as well, and what we call waxy alopecia, this is a spectrum of disease. It can be linear sebaceous nevus syndrome, encephalocraniocutaneous lipomatosis, and they can have intracranial anomalies. They don't always have to have them, but you have to do an MRI to check that. Now, in this child, this is another child with the same condition. I did a corneal transplant, and the child now is 6 years old. His vision is 21/60 in that right eye that I operated on, but he has vision. Now, this is a type of corneal dermoid that I want you to recognize. It's a reticular dermoid. It's flat. It can be unilateral or bilateral. It's there since birth. And if you see this, you must rule out one condition, and that's trisomy 8 mosaicism, because these children can have a subclinical cardiac problem. So we've talked about corneal dystrophies, corneal structural defects due to dermoids, and which systemic conditions you should look for. I want to talk about CYP1B1 cytopathies. More and more this is becoming recognized, right? We did a study where we looked at CYP1B1 related anterior segment developmental anomalies. Now, in Saudi Arabia, you know that one of the commonest causes of congenital glaucoma is CYP1B1 homozygous or compound heterozygous mutations. What's interesting is that in this cohort, we had 3 cases in whom the corneal diameter was no bigger than 11 millimeters, and despite controlling the pressure, the cornea remained cloudy. Now, when we did the corneal transplant, this is what was interesting, is that in the center, Bowman's is missing, and in the center, posteriorly, there's no decimase or endothelium. But in the periphery, it's present. Now, in a control child who had a corneal diameter of 13.5 millimeters, a very hazy cornea because of terrible glaucoma, when we did the corneal transplant there, centrally, the Bowman's is present, and you can see the breaks in decimase membrane, HARB3. In these 3 cases, the corneas remained clear, but the glaucoma was very aggressive. So there is a form of corneal clouding related to glaucoma where you control the glaucoma, the haze doesn't clear, the corneal diameter is not big, and they don't have CHED. This is CYP1B1 cytopathy, and you have to be very aggressive about controlling the glaucoma. Okay, you can see that the first group are all in green. Why? Because they do well with corneal transplant, be it endothelial keratoplasty, be it penetrating keratoplasty, as long as you take into account the age that you're doing it in and modify your technique accordingly. What I'm going to show you now is a group where you can see some are in red, where they don't do so well. And I'm going to try and explain to you why. In iridocorneal adhesions only, what we call Peters anomaly type 1, the evidence is that these children do reasonably well. The papers have been published about this. It is my experience, and I'm sure it's your experience. The other thing you can remember is that if you're worried about follow-up, or if you're worried that you don't want to do a corneal transplant, in this case, you could very easily do a very broad optical iridectomy and give the child vision. Our goal as pediatric ophthalmologists and pediatric cornea specialists is not to do an amazing surgery. It is to give amazing functional vision. That's our goal. No more, no less. So this is a OCT of an iridocorneal adhesion. And what I want you to look at is that this was done courtesy of my colleague Kira Lathrop. If you look where the iris is attached, there is a tremendous amount of fibrosis that goes on in that stroma. So there must be something in that iris other than just inflammation on the touch that is inducing the fibrosis. And this is something that we're working on very deeply at the moment to figure out what that fibrotic event is, to see if we can create a molecule to reverse the fibrosis, reverse the scarring, and therefore not necessarily have to do corneal transplants in every infant. Okay, sometimes the lens fails to separate, and this is what happens. The look of this cornea is different to the iridocorneal adhesion, and you can see that the lens is attached. Now, have a look at this. I want you to notice blood vessels in the cornea. The UBM suggested to me that the lens was attached. I take the cornea off. The lens is inside the cornea. Now, if your lens is inside the cornea, it means it never released the factors it was supposed to release to help the tertiary vitreous develop. If the tertiary vitreous didn't develop, then your meshwork didn't develop. You have an abnormal anterior segment. Can you expect this graft to do as well as a graft that is like this due to iridocorneal adhesion? I put it to you, no, you cannot. But if you label this and this as Peters anomaly, you can't make a logical conclusion as to which interventions are the best. Peters anomaly is a sign, it's not a diagnosis. So have a look at this. I showed you this earlier. This is the child with the keratolenticular adhesion, also known as Peters anomaly type 2. We know that if you take the lens out at the time of doing a corneal transplant, the chances of that graft surviving are much, much, much less. Agreed? So why would you want to do that? Why not do an optical iridectomy and give this child vision that you don't have to worry about? You have to just make sure they're wearing glasses. As they get older, give them a contact lens if you want to. Our goal is to give the best functional vision with the least risk. These are children with Peters plus syndrome. This is a syndrome due to mutations in beta-3 GALTL. It's a glycosylation gene. I want you to notice something. They tend to have a marked thinning in the center, right? They have a long philtrum. They have short arms. They often have a cleft lip and palate. But look at this child, the same child with the same genotype, right eye, left eye. Right eye has iridocorneal adhesion, left eye has keratolenticular adhesion. So now, Peters anomaly type 1 in one eye, type 2 in the other eye. If you ever needed evidence that Peters anomaly is a sign and not a diagnosis, here it is. the same child with the same genotype, two different phenotypes in each eye. There is no argument, there can be no discussion that Peters anomaly is a sign. So if you are prepared to diagnose pneumonia by saying it's a cough, that means you're prepared to say that lung cancer is due to a cough, which means that a cough could be lung cancer or pneumonia. That's how ludicrous our naming is in 2020. In the year of sight, we are still blinded by old terminology. So let's have a look here. Let's see about these red ones, all right? This is the lens separates, but then lens fails to form. If that happens, these soluble factors that are supposed to make the stroma of the cornea clear fail to occur. And so you get a cloudy cornea, a hazy cornea. This has got nothing to do with the cornea. This is not sclerocornea. This is because of a lens problem. Have a look at this. I am sure that many of you have seen this, the silver cornea. If you see the silver cornea, you need to be afraid. Why? Because invariably, there is no lens. This is a congenital primary aphakia. In primary aphakia, they do very badly with corneal transplants because the vitreous is not normal. If you stir the vitreous, it develops these membranes and they go physical. But the stroma is so thin that you can actually get a red reflex. So the thing to do here is control the glaucoma, give them glasses. Why is the cornea opaque? Because Zinn, in 1970, think about that, 50 years ago, he showed that if you take the lens out of a developing chick embryo, the cornea goes cloudy because the lens releases soluble factors that make the cornea clear. And why does this occur? It occurs because of mutations, homozygous or compound heterozygous, in the FOXE3 gene. The FOXE3 gene is a lens epithelial gene. Think about it. No lens epithelial cell, no lens, right? But this is not sclerocornea. What has it got to do with the cornea? It's got nothing to do with the cornea. It is a lens problem. So we talked about lens fails to separate, lens separates but fails to form, lens fails to form. There's one here that I want to talk about. I put it in gray. Let me explain why. This is a child sent to me with Peters anomaly, they said. And I went, okay. But if you look very carefully, and you can't see it on this picture, the child had no anterior chamber. And when I did the OCT, the lens is touching the cornea. Why? Because of PHPV. And I wrote this paper with Anna Metzinger, my research fellow, some years ago, where we talked about cataract surgery in children with congenital keratolenticulated adhesion. It's in JPOS. My technique is to go into the bag, suck out the lens, cut the neck of the adhesion, and then leave the child aphakic. Sometimes I'll put a lens in. I'll show you what I mean by that in a minute. So in this child that I showed you, I did that, took out the lens material. Look how the lens capsule is attached here. Can you see that? Right? And then this is the plaque on the posterior capsule with the stretched ciliary processes. And once I got rid of that, that's what the child was left with. This is the child 6 months later. He has some haze, but now he's got a window through which he sees. He has a contact lens on, no corneal transplant. Do you see? The phenotype makes a difference to what you do and therefore the prognosis. This is another such case sent to me by my very good friend Jan Tier de Faber. Similar case, PHPV causing the lens to be pushed forward. You take the lens out and you have a little bit of haze, but you can get the child to see. So what about primary congenital glaucoma? I know that in Saudi Arabia, you would never get primary congenital glaucoma where you can see the angle, right? This is a normal angle, iris root, ciliary body, and there's no scleral spur because it's a 4-month-old child. And then the meshwork. In the child with congenital glaucoma, you do not see the ciliary body. You do not see the meshwork clearly. It's fuzzy because of this membrane that is hooking up the iris up to the Schwalbe's line. This is the type of glaucoma that you guys, I guess, would often see. When they come to you late, I see this in South India as well. I see this in China. Parents can't afford necessarily to get to medical care early enough, or they ignore it because they think it's not a problem and it's going to clear up by itself. But it can be very severe, and even at birth, so it doesn't even have to be because the parents didn't realize. And for this, I do a combined trabeculectomy, trabeculotomy. Can you imagine if I said to you that the treatment for this is don't worry about the glaucoma, just do a corneal transplant? You'd think I was mad. You see, our ability to recognize what the primary cause is has improved with imaging, but our ability to work out what we do when the primary cause is the lens has not. This is a child who has Axenfeld-Rieger syndrome. She has the typical umbilical hernia. She has, but they can get corneal clouding, maxillary hypoplasia. This is a child with aniridia due to PAX6. See, people say Peters anomaly is due to PAX6. No, the keratolenticular adhesion seen is because there's no iris, which can be due to PAX6 mutations. So let's go a little bit further. I know it's late. I don't want to go into too much detail, but this child has a severe form of anterior segment developmental anomaly. She's born with the lens extruding, and you can see these really odd cysts in the cornea. It turns out that her mother has a mutation, has a change in PITX2, and her father has a change in FOXC1. When the mother and the father give those two mutations to the child, it's like the child has neither of them. And so she gets a severe form. And the problem is that in the PITX2, there's this amino acid that's so important that it's conserved throughout all these different species. So digenic inheritance is going to become more and more common. Here's one that I don't know what's going on, right? I don't know how to classify this. I know that this is a normal iridocorneal adhesion. Here is an anterior segment opacity with vascularization. Iridocorneal adhesion, no vascularization. So I know something funny is going on. And in this child, in this similar child, look, the child came, was like that. 2 weeks later, had this much glaucoma. Any corneal transplant that you do, and I did one, is going to be at risk of failure unless you control the glaucoma. So let's look at outcomes. If you look at the results of the outcomes of transplants, they're very varied and not great. But each series defines the corneal opacity, not in a deep phenotypic way, but in a waste paper basket way. Peters anomaly, sclerocornea, but without going into the depth of what exactly one is. But, you know, why is there a relatively poor rate? Is it limbal stem cell deficiency? Is there a host tissue abnormality? Do we have to redefine success in these children? Well, I did some work with Kira Lathrop, who I mentioned earlier, and we looked at the position of the palisades of Vogt. If the palisades are present, then it's likely that limbal stem cells are present. And what you can do with OCT is you can look at the limbus, and you can look at the limbus as if you were seeing it head on, just on the side here, en face, or from the side. So you're looking at it from over here along this axis. And what you see is, this is remarkable really, you can create a segmented video showing you if the palisades are present. Look here, right there. There are the palisades of Vocht. And here you see them like valleys and hills. When you look at them here, if I can play this, yeah, it's playing, you'll see that you will see at the base here, blood vessels becoming apparent. And you'll see these linear white streaks, a little bit like this, but on the side. There we go. There they are, and you see these blood vessels. So in this way, and this is Kirilathrop, we developed a arm. This is a handheld OCT. And I want to show you an example. A child was sent to me who had been refused corneal transplants in 5 centers in the United States because it was felt that she had limbal stem cell deficiency. I'll show you her pictures in a minute. This is a normal age-matched child. This is the child that was sent to me. Now, it's clear that the palisades are not normal, but they are present, especially with these blood vessels at the base, right? So if I remind you, the base has a big blood vessel here. If you don't have limbal stem cells, there's no need to have that base blood vessel. So this was the child. Look, this was the child who was sent to me. I did corneal transplants. And this is at 3 months post-op. We're now about 3 years post-op. She lives in another state. I don't see her so regularly. I'm told that she has some haze here, but she's got a window of clarity centrally, and she's doing things that she never did before. But she has deprivation amblyopia because we got to her late, right? So this is the paper, if you want to read it, The Palisades of Vocht in Congenital Corneal Opacification. It was my thesis for the American Ophthalmological Society. And what you see is basically that in the majority of cases, except for one, this one here, the palisades are present. So it's not by and large an absence of limbal stem cells that is the problem, although they may not be completely normal. And that's important to recognize. So what is success? Here is two children with unilateral disease. The one on the right, the one on your left had multiple rejection episodes, but the mother was very good at patching, very good at putting a contact lens on, and we got 621 vision out of that right eye. The mother on the child on the right, beautiful cornea, look at it, no rejections, 6 years old, but no patching, no glasses, no contact lenses, vision of 6/180 eccentrically. So how do you measure success? Do you measure success by the clarity of the cornea, or do we measure success by the function? Here's the first child I ever did in Great Ormond Street in 1999. She has iridocorneal adhesions. Look, very little vascularization. And I did both eyes. There she is. And I got a letter from her because she went into university this year. So what is success? You see, I'm going to show you a child. This was her better eye. I operated on the worst eye, did a graft, and it started to reject. And I went in and did another graft very aggressively, very early. I operated on her when she was about 6 to 12 weeks old. She has navigational vision. To give a mother, a child who can walk on her own without a white stick, that is a measure of success. So the question I want to ask the audience, and maybe you could put it in the chat. The question I want to ask is, what central visual acuity does this child have who had bilateral corneal transplants in the first 2 months of life? Think about it. What central visual acuity does this child have who had bilateral corneal transplants in the first 2 months of life? Let me tell you that if you were to look at the transplants, you would think that they had failed because they've got haze everywhere. But there is a window of clarity. His central visual acuity in his only seeing eye is 22,000. Think about it. 22,000. You see, central visual acuity is not the only measure of visual function. Depth, color, contrast sensitivity, spatial awareness are all extremely important. And when you give a developing neurobiological system, which is an infant, some vision, they use it much more effectively than adults who lose vision when they've had full vision their whole life. So let me tell you what I've changed. If a child is bilaterally involved, I wait till 4, even 5 months, because I found that the overall outcome of clarity of cornea is better, and that the end result in terms of visual acuity is, I think, at least the same, if not better, but there's less complications. So we're coming up to around 42, 43 minutes. Here's my take-home message. Deep phenotype's important. Peters anomaly, sclerocornea, they're not appropriate terms in 2020. We really should be talking about primary corneal disease and secondary corneal disease. And protein expression together with molecular diagnosis is likely to lead to a better understanding of what's going on, like what I showed you with the iridocorneal adhesion and the fibrosis. And if I want to ask something of the people around the world who do deal with these children, developmental vision is much more important than corneal clarity. Developmental vision is much more important than corneal clarity. You know, Rumi, the famous Persian philosopher, said, it is not the people who speak the same language, but who have the same idea that can communicate. I hope today, with this talk, that we will develop the same thoughts and same ideas for these children to help them. If you would like to see more information about these, there's a WSPOS channel. There's also my YouTube channel. I have some videos there on 2-incision push-pull for pediatric cataract, but also some videos about techniques of surgery, which I really haven't talked about today. Thank you so much, and I'd be happy to take any questions.
Thank you very much, Dr. Nishal, for the nice lecture. It's really, I think, practice changing and term changing, especially in our area, where we are seeing a lot of congenital corneal diseases, and I'm sure most of the those who work with pediatric ophthalmology cases have seen many of these cases, where either isolated corneal disease or they have some lenticular change with it, iridocorneal. And this presentation really will change how do we approach these cases. I will start with one question. The cases that have some central corneal opacities and you decide to give them dilating drops, and you think that with dilating drops they will do fine. What dilating drops we are using for them? Okay, so if you want to do a trial of using dilating drops, then in Saudi Arabia, most of the children have very dark eyes. And if you use tropicamide, which I use here in the United States, it's not going to work. Yeah. And so what I would do is this. I would give them atropine, but give them the full correction. So you give them glasses for near with the atropine. If they are improving, and you can see that they're taking up fixation, but with the glasses, if you give them atropine without near glasses, then you'll give them amblyopia because they can't focus for near, right? Yes, yes. But if you find they're improving, then I would not waste any more time. Pardon me. I would do optical iridectomies. Okay, good. We'll go over some of the questions. One question: I recently received a neonate with macrophthalmia and axial length of 7 to 9 millimeter only, with absence of the lens and opaque cornea. What's your management in this case?
My management in this case is to counsel to the parents to say, unfortunately, there is nothing that you can do for this child surgically. I would ask you and your colleagues to be very aware of the more recent developments of artificial vision and substitution vision. Now, let me explain what I mean by that. In this child, if the child has a normal MRI scan, normal heart, and normal kidneys, because I would be very worried that they're going to have something like brain eye disease or some other systemic problem. If they have a normal brain, normal heart, normal kidney, then you want to convince the parents to spend a lot of time developing the child through speech and language. Why? There is a product called the brain port. The brain port, it's a camera on glasses that turns the surrounding into a 3D touch image on the tongue. If you look it up, we did a lot of work at Pittsburgh, and my colleague Ellen Mitchell has been working with children on this. And I want you not to say to the parents, there's nothing we can do. There's nothing that we as surgeons can do, but the world is a bigger place for vision than just ophthalmologists. Electrical engineers, computer engineers, mechanical engineers, they are going to help us bring vision to children who were blind before. So please look up substitution vision and then look at the new artificial vision that is being developed. This is not far away, where we're going to stimulate the occipital cortex directly. We as ophthalmologists must be aware of what is happening in the next 5 to 10 years. Hope, which is not false hope, is the essence of life.
Great.
If you give no hope to these parents, then we do more harm than we are doing good as doctors, but not false hope. Do your reading. In my clinic, I have excellent people who know about these, and they come and tell the parents about them, give them the options. But we can't do anything surgically for this child, but we have to make sure the child learns Braille, that we have to make sure the child learns speech and language, that the child learns to navigate. And there are all these amazing things that are available now that were not available 20 years ago. So we must use them.
Yeah, you're right. Question is, another question, what is the youngest age you did keratoplasty for?
So I used to do them as young as 4 weeks, but I've stopped now. Even in unilateral cases, I find that 12 weeks is good. In bilateral cases, as I said, 16 to 18 weeks is better, because the trade-off, I think, is better to leave it a little bit later.
Great. If you have a child who's both congenital glaucoma and let's say primary congenital glaucoma, and they had some corneal opacity that persist after controlling the IOP, when you decide to go for keratoplasty in these cases?
Okay, depends. So there are two things, right? And I can tell you this because I did this case on Monday. I had a child who had congenital glaucoma. I did trabeculectomy, trabeculotomy. I controlled the glaucoma, but the vision in one eye was very poor because of Harb's tree, only Harb's tree and a little bit of haze right in the center. The other eye, the Harb's tree was around, and so his vision was 20/60. The affected eye was 2200. So on Monday, I did an endothelial keratoplasty. I took away the Harb's tree and I put the endothelial keratoplasty on, right? That's a much better prognosis. Now, if you have a child that has a corneal diameter of 14 millimeters, and for some reason they got to you late, and now the stroma has got fibrosis, you can try endothelial keratoplasty, but it's not likely to work Now the only thing you can do is a penetrating keratoplasty. But you have to be absolutely sure that the glaucoma is controlled, because if it's not, the graft will fail.
Great. Thank you very much, Dr. Nishal. It was a very nice presentation. I'm sure people will get a lot of it, and many things will change, either in diagnosing, classification, and even in management of these cases. So thank you for joining, and thank you for your time.
Okay, so there's a couple of questions here. Can I ask these, answer these?
Go ahead. If you have questions, go to them.
Yeah, it says, how do you address the prognosis of success to the parents?
Yeah.
I show the parents my classification. I show them the green and red. I show the parents where the child lies. And if it's in red, I say if it's unilateral, don't do anything. But if it's bilateral and it's not congenital aphakia, I say it's worth giving the child a chance. But the prognosis is not good, right? If it's in green, then I say, look, I think the prognosis is good. The child could still get a rejection. We may still have to deal with that, but the prognosis is good. So the classification for me has really helped. In Peters anomaly, yes, you must do a full assessment. Kidney, heart, brain, right? And then I don't understand, what are the CCC of the graft for child? I don't know what CCC means.
I don't know what's also.
Do you mean the cell count? I always try to get a graft, donor graft with a cell count of over 3,000.
Okay.
And under 30 years of age. What factors contribute to graft failures? Suture removal. If you have an infant and you don't remove the sutures by 6 weeks, you get an epithelial rejection. Glaucoma must be controlled. They must, whenever they have a vaccination, you must up the steroids topically, because the vaccination causes an immune response. If you have a case of CHED in one eye and DSEC in the other eye, in my hands, I would prefer to do a DSEC in CHED in any child over the age of 5. Under the 5, if it's severe, I do a PKP. Because under 5, the anterior chamber is not deep enough to do a safe CHED.
So DSEC above 5?
I do DSEC above 5 because I have a deep enough chamber. And then, well, 4 is the youngest I've done. 4 is the youngest. But yeah, so 4 and above. 4 and above. But if they're under that, I do a PKP if it's severe.
I think you mean the criteria for the graft, as you said, the cell count.
Okay, so the cell count and the age under 30.
Question is, isn't 6 weeks very early for remove suture?
No. In an infant, so this is honestly the truth. In an infant, the quickest I've removed all the sutures is 3 days.
Wow.
So what you have to do is you do the first day post-op, then every week you see the child twice a week. This is a baby, an infant, twice a week until 6 weeks. If you get one loose suture, that's an emergency. You have to take them up and take all the sutures, and they can start to have blood vessels.
Okay.
So you have to remove the sutures by 6 weeks in an infant. Now, over the age of 1, for every year over the age of, like, let's say 10 months, you add 4 weeks to the suture removal. So if the child is 2, it's 6 plus 4, right? Which is 10, like that.
Okay.
Okay.
Go ahead. I noticed that with BKB for CHID results is in better graft clarity, and for CHID takes longer time for graft to clear. So,
you see, I think the experience here is different because you are seeing probably more severe types of CHED that I'm seeing. I see the types of CHED that are mild. They get to me around 4 or 5 years of age. Their vision is 20/80, 2100. And I do a endothelial keratoplasty and they do great. But I think the ones that come to you that are very severe with the nystagmus, very young, you know, babies, then I would do a PKP.
Okay. maybe the last question, since you are removing suture early, why don't you use tenovical?
Because tenovical incites white cells that cause rejection.
Yeah.
Do I see? No, that's a very interesting point that person has made. Very, very interesting point. So there have been some studies, well, actually 2 studies where they did corneal topography, but there were some children who got flattening, patients, they weren't all children, and some who didn't. So I don't know if it's to do with the DSEC or the genotype.
Great. I think there are no more questions. So
Okay.
thank you very much.
I very much appreciate being invited. I want to thank you all, and I wish you the very best. Please be safe at these unusual times.
To you also.
Take care. Bye-bye.
I think you will be us within this week, I think, with Kate.
Yes, yes. And remember, tomorrow morning, 9 o'clock US time Eastern, 2 o'clock London, 4 o'clock Saudi Arabia.
Yeah.
Very good webinar on ROP.
Yeah, and in WSBOs.
Yes.
Thank you. Thank you very much.
Take care. Bye-bye.
Thank you all for attending. Thank you very much.